Hello, my name's Derek Manny. I'm going to be doing a quick talk about COPD and what we can do for these patients. This was written by Lorna Ballo, Rita Hunt, myself, and reviewed by Dr. Michael Shim. What is COPD? COPD abbreviation is chronic obstructive pulmonary disease. It's a little bit vague, but we'll discuss that a little bit more. It is often preventable and treatable, meaning that with lifestyle changes and treatments, we can slow the process down. But again, it is not fully reversible, meaning that we can't cure it altogether. Quick facts: COPD is a major cause of disability and a fourth leading cause of death globally, soon to be the fifth as COVID takes over number three. It costs healthcare an estimated $49 billion a year and rising. Among the leading causes of death, COPD is the only one that is continuing to increase in prevalence, meaning that it's continuing to get worse. COPD is a lung disease characterized by chronic obstructive lung flow and again is not fully reversible. And COPD is part of the hospital readmission reduction program, meaning that if a patient has to be readmitted, the hospital can be fined or lose reimbursement within 30 days. Risk factors for COPD. This is a big takeaway. The number one risk factor for COPD is cigarette smoking. That's why we are seeing the patients where we see them today. Other causes is genetic syndromes, alpha-1 antitrypsin, pollution, occupational exposures, but by far cigarette smoking is the most major factor. Types of COPD. So what happens to our body? So you have chronic bronchitis, which means persistent long-term cough and mucus production, and emphysema, meaning gradual destruction of the lung air sacs. I'll show pictures to help it a little more. So here's your chronic obstructive bronchitis. A patient type we know to call these as blue bloaters. What happens with this is your normal airway looks like this, nice wide opening, but with chronic bronchitis, what happens is you get inflammation within your airways and then increased phlegm production, which causes those airways to be narrower even more. That's why you get that exhaled wheeze that we hear when we listen to breath sounds, because that air is trying to push through the small space. Emphysema. With that, you have the breakdown of your air sacs. So normally we have these nice little elastic grape-like appearance where the air comes in and it gets pushed right back out. But with emphysema, what happens is these all get destroyed, and so it creates this large bulbous appearance where the air gets trapped in there and has to be forced out by the patient. This causes the patient to do a lot of work, and this is why we have what's called the pink puffer. This is a quick kind of picture of what you might see and how different they are. Again, your chronic bronchitis is going to cause cyanosis, overweight, edema, peripheral edema throughout the body. You're going to have rhonchorous, that cough, that expiratory wheeze, elevated hemoglobin. Whereas emphysema, patients working really hard, so they're going to be very skinny, likely older, severe dyspnea, that pursed lip breathing, quiet chest. Again, look how elongated this lungs are because there's just like all this wide air. So it's going to be a very black looking chest x-ray. Your heart's going to be smaller because of it's dropping down with um, with that big lungs spreading them out. This is a quick look at the physical appearance. So you're going to have two different looks of a physical exam. You're going to have your chronic respiratory exacerbation, and then you're going to have an acute exacerbation. So your acute one, your sats will be very low. Patients can be really working hard to breathe, and those are the ones we expect. But this is going to be your chronic exacerbation, which shows that it's a elongated process. First off, you're going to have clubbing because of the patient's hypoxic nature. A lot of times you'll see by their nail beds that it has this thick rounded appearance on the end of their fingers. Tripoding, again, they're trying to get the air out as best they can, and so they may sit forward and keep their hands on their knees or on a table and try to help elongate their chest and push that air out. Pursed lip breathing, blue lips, that's kind of an easy sign of the patient having long-term difficulty breathing. Your accessory muscles, you may have nasal flaring, increased neck muscles, abdominal breathing. Your barrel chest, you may have heard of, which just means your elongated, really wide lung area, taking up a lot of your thoracic cavity. And again, your heart will be, your heart sounds will be in a different place than you expect. Rather than having it be at the normal area, it's going to be dropped down because of the long lungs spreading out the area of the chest cavity. The heart actually dips down a little bit lower than you would expect. And of course, your breath sounds, right? You're going to have your expiratory wheeze or very reduced, diminished breath sound. So what happens to not only our lungs, but our system? So we talked about our lungs. You're going to lose that elastic recoil. Think of an old rubber band or an old elastic band that can no longer just bounce back to the position that it had. Or you're going to have that airflow limitation, that small airway that leads to air trapping and hyperinflation. But it does more than just our lungs. It hurts our body as well. So our systematic system is, you'll see because of the calorie expenditure. Like I said, these patients are really working hard to breathe. It's like a prolonged exercise for them. So you'll see nutritional abnormalities and weight loss. And the inflammation is more than just your airways. It's actually in your all throughout your system as well. So you'll see cardiovascular disease, corporal pulmonale, pulmonary edema, atherosclerosis, and all of those that will cause your body to have that inflammatory response. And if you think about it, if you're having a hard time even getting around to move, your quality of life is going to take an impact. This often leads to depression, E2H abuse, sleep disorders, which again leads to lack of mobility and lack of wanting to take care of yourself. So this just shows that your disease progression and why this is such a hard disease to treat and take care of is because it's a overwhelming cycle, right? You get your diagnosis COPD because of the air trapping, hyperinflation, which leaves you breathless, which you get deconditioned because you're too short of breath to do any activity, which then your lungs get used to that reduced exercise capacity and lose their strength, which leaves you to poor health and poor quality of life, which makes you not want to do anything, which kind of, and it's a big sad circle, which is why it's important to know all of our different social work and chaplain and all of our key players in a hospital to make sure that we're all on board and helping these patients the best we can. So supplemental therapy, what else can we do? The big thing is smoking cessation. That will reduce the rate of the FEV1 decline, meaning if we quit, our lungs won't continue to get worse, and it will help the patient's quality of life expand out longer. Pulmonary rehab, just like any other type of exercise, if we can get the patient to improve their exercise capacity and decrease dyspnea, that can really help. And studies have shown that it can decrease healthcare utilization for up to 18 months after completing a rehab program. Home health PTOT, again, your therapies, that's often an option for homebound patients. Oxygen can sometimes help improve quality of life. Vaccinations, so infections are terrible for these patients, as you can imagine, so preventing those infections is very important. Like I said, patients are working really hard, reducing, expending a lot of their calories and probably quality of life and depression, maybe not eating as well as they should and things like that. So nutrition's a big part for patients. And then lastly, surgical options. There are a few patients that qualify for certain options like lung transplant and reduction of surgery. Diagnostic tests. So, how can we determine if one has COPD and how bad it really is? So, the severity of it. The number one takeaway here is pulmonary function test is the cornerstone. The really the true way to test to see if someone has COPD is to do a pulmonary function test. Chest CT can be helpful. Chest X-ray doesn't really help, but a CT has better sensitivity. And ABGs. An ABG can show if someone has chronic moderate hypoxia and how their body is compensating for that. So you might have heard of the 50-50 club. Oftentimes a patient will have a 50 PO2 and a 50 PCO2 that their body compensates for. So even though they don't tell you that they're feeling really short of breath or anything, by their blood gas, you can tell that they are a chronic retainer. So, pulmonary function test. This is your most important test for testing severity. This is what a pulmonary test will look like. And I know it's overwhelming, but I'll break it down for you real quick. So your blue line here, that's your COPD patient, and your orange line is a normal patient. So what this shows is time and then the volume of air in your lungs. Okay, so your kind of key indicator is your FEV1, meaning after 1 second. So as you can see, after 1 second of blowing out, a COPD patient has only gotten rid of 2 liters of their oxygen, of their air in their lungs, whereas a normal patient has gotten rid of 4 liters out of their lungs. So that's a huge difference, right? And so overall, your FEV1, FEC, if it's less than 70%, there's a high likelihood that the patient has COPD. And this patient has 51% on this test. Gold classification. This is a quick breakdown. I'm not going to go super involved in it, but this is a way that globally doctors and have gotten together to say, how can we assess the severity of COPD and what kind of treatment we should give. So it looks at it assesses severity by looking at your symptoms and your exacerbations and leads to a suggested treatment. So Global Initiative of Obstructive Lung Disease. So it breaks down into 4 categories, A, B, C, D. A is the least, this is your lowest severity, and then D is your most severe. So as you can see, your symptoms, mild or infrequent. Maybe you just get a little breathless when you're moving around quickly or walking up a hill, etc. Low risk. Don't really have any exacerbations last year and you haven't been hospitalized. So with those patients, you're just going to need a rescue, meaning if something happens, a short-acting bronchodilator, all right, maybe PRN as needed. But once you get to severe, moderate or severe, so you're not able to walk very far without having to catch your breath, but yet your exacerbations aren't too bad. So with that one, you're going to want a maintenance, so more of a long-acting bronchodilator, right? Something long-term to just to help with these symptoms. And now as we get more severe, so you don't get super breathless, but you're having these more frequent exacerbations or maybe being hospitalized. This shows that you're going to need a combination, likely a maintenance plus a rescue for symptom relief to try to keep you out of the hospital. And lastly, D is your most severe, right? You can having trouble walking far distances, plus you're getting a lot of exacerbations, and this is when you kind of need to throw the whole kitchen sink at them. You may have to throw in an inhaled corticosteroid. And for those, you want to make sure to rinse out their mouth, because that's when they get thrush. So for all patients, what you want to make sure to do is quit smoking, take your vaccinations annually to make sure you keep rid of those infections, regular activity, try to keep your exercise tolerance up there, and proper inhaler technique, right? If we're wanting to give these medications, we want to make sure they're getting down to your lungs and that you're using them properly. Which brings me to, why is proper technique important? Ineffective technique can lead to poor disease management, right? If you don't know that you're taking them right, then how can we treat you well? And increase in exacerbations. So again, if the medicine's not getting down into your lungs, it's not going to help you and you're going to end up back in the hospital. So key elements. We're going to show later that there's tons of inhalers out there. But what I want to make sure to tell you is that overall, there's a few steps that almost all of them have in common. All right, you want to go ahead and shake the container. You want to sit up straight or stand. You want to make sure to have as much area that you can breathe in as deep as you can. You want to exhale fully. So get your breath out. Make sure you're ready for a deep breath, and then take a slow and deep breath. And as soon as you initiate the medicine, and hold it for 5 to 10 seconds. Okay, so initiate the med, and then slow, deep, and hold. And then I like to use fingers for elaboration. So 1, 2, 3, 4. And so what this does is that slow, deep breath right after you start the medicine allows that all those particles and all that medicine to go down into your lungs and not just get sprayed in the back of your throat. Remember, rinse your mouth out if you're using a steroid. So it's not easy, right? Even I got confused going over the slides. So that's why it's so important to reinforce this, educate patients on it, encourage them to talk to their pharmacist, follow up. Even if they say, oh yeah, I know what I'm doing, ask them to do it in front of you so that you can help give them tips. So why is this technique important? A lot of times in TV shows or movies, you might just see them go, take 2 quick puffs and a quick breath. And so what happens with that is all that medicine either just goes right in the back of your throat. So how this works is it displays little particle size droplets of medicine, and what we want is for that to go down deep into your lungs. So that slow, deep breath allows the meds to go deep into your lungs, into the alveoli where we want them to go. Inhalers. This is an old slide. I think there's more than these now, but these are the inhalers that are out there. You've got your short-acting, your corticosteroids, combination, anticholinergics. Overwhelmed yet? Think about your patients, right? This is very overwhelming. So MDI, this is the one that we're kind of all familiar with and that we know about. And again, don't watch the movies and see the quick, that's not how you do it. You want to sit up straight, tilt your head back, exhale, and hold it in your mouth. And at the same time that you press the button, you want to start taking a slow, deep breath, and you want to hold your breath for 10 seconds. If you have to take more than 1 puff, you wait 2 minutes and do the same thing again. It's not a quick process. It's a slow, deep breath and hold. Spacer. Spacers are really nice and can help with poor technique. Like I said, it's kind of difficult to put it in your mouth, push the button and breathe at the same time, hold your breath, all of that. And so what a spacer does is it has protective, it has this covering on the inside that prevents the particles from sticking to it. And so what happens is once you push the button, it goes in there, and then you can take your time and kind of take that slow, deep breath into your lungs. So it helps with coordination and makes it a little easier. And if you have to take 2 puffs, make sure you do not just push 2 puffs into this at once. You take 1, do the whole process, wait for 2 minutes, take another one. Okay. And now I'm just going to go through a bunch of different types and why this can be overwhelming. Spiriva, you have a pill that goes into the inhaler and then you inhale it in. We've had patients that swallow the pill and then breathe into the inhaler. So education is important. Neohaler, again, a little bit smaller. Pill goes inside there. Press air, it's a little different. There's a button that you press on the side. Green shows it's ready to go. Breathe in, then it turns red. There's counter. Twist haler, counter on the bottom. You twist it. Breathe in. Respimat, use the top, which means you turn. Take the cap off. Breathe in. Overwhelmed yet? I know I am. I did the slides and I got overwhelmed. Again, imagine what your patients are feeling. Combine this with all the other medicine that they're taking and overall being sick and not feeling well, it can be, there's no wonder that patients have a hard time taking their inhalers right. So it's so important to make sure that we make them feel comfortable and confident with their medications. So what's nice is that UVA is trying to just use one type of delivery system to make it easy for everyone, and they're using what's called the ellipta. The ellipta delivery system, which you're most likely to see at UVA, kind of looks like this. Okay, there's a dose number on the bottom. You're going to pull it back until you hear a click, and there's a vent there. You want to make sure to not cover the vent with your fingers. You're going to breathe out, put the mouthpiece in, do the same thing, hold your breath for 5 to 10 seconds, and then slide it back closed. It's a close-up of it, okay? What's important is make sure your patients know that once that click happens, they need to breathe in and their medication is dispensed. We've had patients that moved it up and down as if playing with a widget toy, click, 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 and then they're surprised why they're not feeling better when their counter's at 0 because they just wasted all their medication. So um, the counter has a neat little visual, so you count down your doses. It starts to turn red when you're getting low. Once you hit that 0 mark, you need to replace the inhaler, and once it's all red, you realize that the inhaler is empty. So that's great, right? Now, what's a drawback to having it all look the same? Well, they all look the same. So I'm not going to make you memorize these names or anything, but realize that this one's long acting, this one's a steroid, this one's a anticholinergic, this one's a combination. So, just know that, your nurses out there, when you just hand over a med, they're going to be different ones, the ones that you're handing over. And again, none of these are rescue inhalers for immediate relief. So if a patient's really short of breath, they still have to use an MDI or a different type of inhaler. So it's important for patients to know that. Nebulizers. I'm just going to touch on this real quick. So with the ideal technique, when a patient uses inhalers well, nebs and inhalers are found to be about equally effective. Some nebs can actually be cheaper depending on insurance and needs like that. So that's why you might see some patients taking inhalers. And they may work better if patients are unable to use them properly. So if you have coordination problems or inability to use the function of the inhaler, sometimes nebs can be beneficial, and especially a face mask where they can just breathe in. Nebulizer can take, downside is they can take longer to use, can cause infections, require home equipment, things like that. So RTs will provide this care at UVA. Comorbidities. So many of our patients have multiple problems that can make inhaler use even more tricky, right? Rarely do we just have a patient with COPD and nothing else. So you're not alone in this, though. Occupational therapy consults can be a great way to see what their function is and how their technique may be improved and help educate the patients. So there's a lot of comorbidities out there, right? Osteoporosis, diabetes, muscle weakness, tremors. These comorbidities can lead to weakened hand function, weakened strength. Maybe they don't feel um, not able to feel the inhaler correctly, or know which tasks to do, when to take what, follow a medication schedule, visual impairment. Maybe they can't see the counter on the inhaler. So these are all important things to realize and to help keep an eye on so that your patient's using their inhaler correctly. OT is available for evaluation with inhalers. They do a great job with our COPD patients. They help realize how they can manipulate the inhalers and help coordinate their use with the nursing. They help with oral hygiene, making sure the patient rinses their mouth out to prevent thrush. And then if there is an impairment, they help them make up a strategy and how can they improve their coordination. They may modify the task by use 2 hands, use adaptive equipment, write out steps, pictures, things like that, practice breathing and strategies, or do some hand exercises to increase the strength. So they have a lot of tools in their skill set that can help with these inhalers. Remember, your OT is available via consult. It's a great resource for helping evaluate your patient's technique and adaptations that may be needed. These are some great pictures of kind of the different techniques that that a patient can do. If 2-hand technique, if they're having a hard time using the strength with just one. Sometimes a button maybe easy for us to push, but it's very difficult for them. So showing them that you can push that button a different way. There's a pill or small device. Sometimes it can roll away on them. So using material to make sure that things don't roll away and get lost. And again, you don't have to use your fingers. There are other ways that we can trigger the inhaler to make it helpful to us. And what about education resources? Again, I've explained a lot, but there's some great resources out there, and they're already in Epic, which is nice. So if you go to Epic and you go to the top right page of the page where your logout button is, you'll see this resources tab. It has a down arrow. If you click down on that, there's going to be this patient education. They have some great videos on COPD and also some great printed material under patient education repository. If you click under therapies, you'll see some great handouts: dyspnea with shortness of breath, energy conservation for both in hospital and everyday living. So there's resources out there. There's social work chaplain, different OTPTs, RT. There's a lot of therapy. There's a lot of assistance and teamwork out there. So let's work together. So in conclusion, COPD is a prevalent and debilitating disease. Our COPD patients require disease-specific education and medication instruction. This includes promoting an interdisciplinary team care plan that begins with diagnosis and continues throughout their transition to home. So again, this is a population that really struggles and is is a frequent readmission and frequent person that we see. So make sure that we come together as a team and prevent them from happening and give them as much education as we can. Thank you for your time.